Good afternoon. Welcome to UCSF Department of Medicine Grand Rounds. Hope everybody had a lovely Thanksgiving and nice to be here today. We're going virtual because our speaker is a visitor from Ann Arbor, Michigan. The topic today is one that we are all thinking an awful lot about, and we're thrilled that today's speaker really is a national expert in the topic. The topic is preparing clinicians for diagnostic artificial intelligence tools, teammates, and the need for training. This is very front of mind. I just chaired a conference for the Macy Foundation in Atlanta 2 weeks ago with really national and international leaders chewing on the topic of basically the Venn diagram of AI meets medical education. And one of our participants was Cornelius James. And so we're thrilled to have Cornelius with us today. He is assistant professor of medicine in the departments of medicine, pediatrics, and learning health sciences at the University of Michigan. He's a general internist and general pediatrician. He holds the James Williscroft Endowed Award in Humane Patient Care. He's had a number of educational roles and educational leadership roles at Michigan, including directing their evidence-based medicine curriculum and serving as associate program director for the residency. He's won a number of teaching awards in the Department of Medicine, including the Kaiser Excellence in Teaching Award, the most prestigious award given by the University of Michigan Medical School. Uh, he was one of 10 inaugural National Academy of Medicine scholars in diagnostic excellence, which is where I first met him and actually mentored and continue to be privileged to mentor Cornelius in his career, which has been wonderful to watch. And he has studied and become really quite well known for his work in thinking about AI to augment clinical reasoning and how that syncs up with our own human brains and human systems. Obviously, a hot and important topic for all of us. So, Cornelius, welcome virtually to San Francisco, and we look forward to hearing you talk.
All right, wonderful. Thank you so much for the introduction, Bob, and really appreciate the opportunity to speak with everyone. It's in the 30s here. I'm assuming it's a bit warmer out in San Francisco, but we are still doing just fine out here. I'm going to go ahead and share my slides and go ahead and get started. I do want to note that I do not have any disclosures. And what I'm hoping that you'll be able to do by the end of this presentation is describe describe the historical evolution of diagnostic artificial intelligence. And then also identify some examples of AI-based tools that are designed to augment clinicians' diagnostic reasoning, summarize the current state of AI integration into diagnostic reasoning curricula, and then lastly, recognize initiatives to begin preparing clinicians to integrate AI into their diagnostic decision making. And I should have also included another bullet point down there when it comes to objectives. It's to just kind of, I'd say a goal is to also just kind of stimulate some discussion and some thought about what this could potentially look like in medical education, in clinical practice, because not no one currently has the answers to many of the questions that I'm going to pose today. So I usually start these presentations with a quote from Francis Peabody. I was given this paper, The Care of the Patient, back when I was a third-year medical student at Wayne State University, and I was wondering why my family medicine preceptor gave me this paper. But I'm so thankful that he did so, because I come to it every now and then, and I say as I've continued my work in this space, I've returned to it a few times. So in this landmark paper, The Care of the Patient, Francis Peabody said, the art of medicine and the science of medicine are not antagonistic, but they're supplementary to each other. So this is a reminder of the importance of connecting with patients, human being to human being, sharing in our common humanity, while also leveraging those scientific advances, including those technological advances as we continue to care for our patients. And he also said in that paper the significance of the intimate personal relationship between physician and patient can't be too strongly emphasized. So it's my hope that as we continue to study and use these technologies, that they'll allow, or that we'll be able to leverage them to allow us as clinicians to spend more time building relationships with patients, so that we can partner with them and spend more time truly caring for them. So I'm going to go ahead and continue. Many of us are likely familiar with this report released back in 2000 by the Institute of Medicine, now the National Academy of Medicine, where they stated in this report, to err is human, that there's between 44,000 and 98,000 deaths in the US annually due to medical error. This report also shined light on the issues related to diagnosis or diagnostic errors that contribute to these human errors and ultimately these or contribute to these deaths. So recognizing the impact of diagnostic errors specifically, the National Academy of Medicine subsequently published in 2015 the Improving Diagnosis in Healthcare report. And in this report, they provided a few goals, or actually a number of goals and recommendations to decrease diagnostic error and improve the diagnostic process. And they defined diagnostic error in this report as the failure to establish an accurate and timely explanation of a patient's health problems or communicate the explanation to the patient. And these errors can occur at multiple levels. They could be clinician level, system level, organization level errors. But ultimately, this report provided recommendations to address and or mitigate errors that can occur at any of these levels. They also provided this, I'm sure, well-known process that they describe as the diagnostic process. And this allows us to appreciate what must be done to ensure this process allows us to appreciate what must be done to ensure that patients receive accurate and timely diagnoses and subsequently receive the treatments that are necessary to address their health problem. This process also allows us to appreciate where things could potentially go wrong and where we and how we could potentially identify methods to ensure that this process is improved and that we don't have those errors that could occur, as I mentioned earlier. So in the report, in that National Academy of Medicine report, this improving the diagnostic process, addressing it, and ensuring that clinicians are able to effectively move through this diagnostic process, it was described as a moral, professional, and a public health imperative. And I'm sure many of us would agree with that. I'll also add that we should be thinking about the role that artificial intelligence and machine learning could potentially play in this diagnostic process. So how can it augment what we do at each step of this process? I anticipate that AI will eventually play a significant role at each step within this process. And I encourage you to begin thinking about some of those ways in which it may play that role. So I mentioned a few goals that the National Academy of Medicine provided related to diagnosis. And the first goal is related to facilitating effective teamwork in the diagnostic process among healthcare professionals, patients, and their families. And I'll pose a question here, and I'll revisit this question a little bit later in the presentation, but think about the current or more recent technological advances and think about who we consider to be members of these teams, or think about the impact that technology will have on the way that we interact with members of these teams. I'll kind of spill the beans, so to speak, and let you know that I do suspect that in some circumstances or some instances, AI will serve as an integral member of healthcare teams that we'll have to learn to collaborate with. A second goal in the report was to enhance healthcare professional education and training in the diagnostic process. So this includes ensuring that healthcare professionals receive the training in clinical reasoning and teamwork, communication, use of diagnostic tests, application of test results, and also use of health information technology to augment that diagnostic process. A third goal was to ensure that health information technologies support patients and healthcare professionals in the diagnostic process. And there was a brief mention in the report about artificial intelligence or natural language processing, but they noted here back in 2015 that we were relatively early in development. Again, I'm going to bring up or note that in that report, tools and technologies were mentioned. However, the role of tools and technologies, you can see here that it's kind of outside of those diagnostic team members. And in some cases, when AI is functioning as a tool, I agree with that when it's performing various tasks. But in some cases, again, I encourage you to think about instances where you could potentially see these technologies functioning as teammates. So, at the time of the report, it's interesting to kind of think about how we were doing when it comes to preparing learners to reason clinically. And this question was addressed in a 2017 cross-sectional multi-center study of clerkship directors in the US. And this was based upon 2015 survey data. And they had a response rate of about 74%. And as you can see here, their perception of students who were entering the clerkships when it came to their clinical reasoning, they didn't feel great about it. You can see that the students, or the clerkship directors, when it came to concepts in clinical reasoning, they rated students lowest when it came to dual processing, which I'll talk a little bit about in just a little bit, but they rated them highest on generating pretest probabilities, and I'll talk about that a little bit in a little bit as well. Uh, Clerkship directors regarding how the importance that they placed on learners being able to effectively reason clinically, or the specific topics related to clinical reasoning. They noted that that intuitive and analytical reasoning, they rated that as least important, but they rated intuitive and qualitative reasoning at where are we? There we are. Yep, intuitive and qualitative reasoning as least important, whereas they rated use or estimation of pretest probabilities as most important entering the clerkships. So that was back in 2017, and people began to do some great work and start to think really hard about how we began to teach our learners to reason clinically, and more specifically, how to get them to effectively reason when it comes to solving a diagnostic problem. And a consensus group or group came together and they generated these recommendations back in about 2019 or so, where they suggested that there are some foundational concepts that learners should embrace, that they should master if they're going to be effective in that diagnostic process. So this isn't an exhaustive list here, but they include things like medical knowledge, dual processing, recognizing biases, uncertainty, and so on. And they also mentioned that there are some desirable attitudes that are necessary for learners or clinicians to effectively engage or participate in that diagnostic process. So they mentioned things like empathy, humility, integrity, skepticism. And again, this list isn't exhaustive, but you can kind of appreciate some of those uniquely human aspects or features of that diagnostic process that were emphasized here. Even before we started talking about things like large language models and so on. So this group came up with 12 competencies that they organized into three domains: individual, team-based, and systems-based competencies. I'm not going to go into a lot of detail about what those competencies were, but I'd encourage you to take a look at this paper. It's very helpful as we think about those competencies, or those things that learners should know if they're going to be effective diagnosticians. So this figure was published back in 2019, only about 5 years ago. I graduated from residency in 2015, so that doesn't even seem that long ago to me. But think about it, 2019 is where we were talking about, or where they were talking about a new field, right? Or diagnosis education, right? So I emphasize that here because it just kind of allows us to appreciate the amount of work that we have to do when it comes to educating clinicians, educating learners about that diagnostic process or effective performance in that diagnostic process. But we now also have this technology piece that we have to think about as well as we develop these educational methods in medical education. So perhaps we think about here, whether or not, artificial intelligence Is it how does that come into play when it comes to this diagnosis education? Are you comfortable with where I place artificial intelligence or diagnostic technology here, as I placed it here next to diagnostic technology, but perhaps you think it should be here instead, where we talk about that foundational literature or foundational concepts that are necessary for learners to engage with or learn if they're going to, again, be effective diagnosticians. So as we consider the role of AI in the diagnostic process, it's also important for us to have an understanding of how clinicians think. And I'm not going to spend a lot of time on this, but I mentioned earlier this dual process theory. So, in summary, we're talking about an intuitive versus an analytical way of thinking. Pattern recognition versus, which is the more intuitive way of addressing a diagnostic problem, versus that hypothetical deductive analytical way of thinking, or even a Bayesian or probabilistic method of reasoning. And those are going to be impacted by things like knowledge, experience, and even the context. And I emphasize some of these things here because I want to just kind of highlight or make sure that we are aware again of some of those uniquely human characteristics that we're going to have to consider or think about as AI sort of makes its way into these diagnostic teams, either as tools or teammates. So this may be a figure that is familiar to many of us. So I mentioned intuitive thinking versus system two processing. So that's or system intuitive thinking or system one processing versus that analytical or system two processing. So here, the system one is often defined or described as fast, right? It requires very little working memory. So we can see with these here on in the system one processing, we have about 4 bold arrows that are kind of emanating from that. And that's suggesting that it's a fairly fast and rapid process compared to that system two processing, which again is that slowing down, which may involve, taking that step back, obtaining or carefully obtaining that history, physical exam, interpreting the results of diagnostic tests, generation of a hypothesis or differential diagnosis and a working diagnosis, and then updating that hypothesis based upon new information. So we as clinicians, we fluctuate between these two. And I won't say that one is better than another in all circumstances, but certainly in some situations or circumstances or contexts, one system of thinking could potentially be more effective than another. And also, you will note here that there are potential overrides where one system may override another system depending upon the context or the circumstance. So again, just kind of think about, how you work through the process of diagnoses and the vacillation, so to speak, or how you may go from or move from one type of thinking to another, and begin to think about again, how AI or artificial intelligence looks within these types of diagnostic or these types of clinical reasoning or these methods of clinical reasoning. Now, I will say that, while there is the potential for error with both of these types of thinking, with either system one or system two thinking, system one thinking tends to be a bit more prone to these cognitive biases. So, because we rely on these heuristics or these mental shortcuts, so to speak, and these are certainly very important, like literally important for life and death, but they're certainly very important. But if they fail, or if they are inaccurate, or if there's a problem, if it's inaccurate, it could potentially lead to these cognitive biases that can impact the diagnostic process. And here I list a few of those, and I won't define those, but some of these I'm sure are likely familiar to many of us. The other thing to kind of think about is how we're calibrated, right? So as we engage in the diagnostic process and we receive feedback regarding our performance or the outcome of the diagnostic process, this leads to calibration. And this figure here kind of illustrates the importance of that feedback because if feedback isn't received, unfortunately, the default is often to treat the outcome or what may have happened as favorable, and that could potentially impact a clinician's calibration. So, how clinicians are calibrated is very closely related to their uncertainty or their comfort with uncertainty. And this may look familiar to some of us as well, but so when we think about calibration, we can define it as the relationship between diagnostic accuracy and clinicians' confidence in that accuracy. And there are a number of types of uncertainty, which I list here. And as our colleagues have previously published, this is a pretty useful model as we kind of think about, where clinicians are when it comes to their uncertainty and accuracy and potential dangers, right? So imagine that danger in that fourth quadrant where we are not only inaccurate, but we are certain, right? And think about how artificial intelligence could potentially move us perhaps from one quadrant to another. So clinicians, as we know, clinicians have lots of competing demands that impact their ability to effectively diagnose and simply care for patients. And as the figure on the left shows, we have limited cognitive capacity to consider more than 5 facts for any given decision. But as you can see, there's so many other potentially relevant facts or things that could be relevant to a given decision that we have to make that we're just incapable of including in including in our working memory during a diagnostic or any other decision. We also know that we're faced with a number of administrative burdens. This is a significant contributor, as I'm sure many of us know, to clinicians either planning to leave or actually leaving the profession. And while I don't suspect that artificial intelligence is going to solve all of these problems, I do suspect that it will play or that it can play a significant role. So that brings us to a bit more discussion about artificial intelligence. We kind of went through that diagnostic process and that history because I think it's important for us to kind of appreciate that as we talk about curricula with AI or that include AI or using AI to augment diagnostic decision making, we are still fairly early when it comes to developing effective curricula that teach learners to effectively reason clinically or to engage in effective diagnostic reasoning. So I'm going to use this definition of artificial intelligence just kind of as our operational definition. There are a number of definitions out there, but we'll use this simple definition of AI as the use of computers to perform tasks that require objective reasoning and understanding. And there are multiple domains. There's machine learning, deep learning. I'll touch on a few of these. The same touch on a little bit of natural language processing, but consider kind of breaking this down during this talk into narrow, which is a more task specific AI versus a general AI or a more generative an AI that can perform multiple or various tasks. And our colleagues at Google described these 3 eras or phases of AI. They described this AI 1.0, 2.0, 3.0, and I'm going to kind of use this framework as I move through the rest of my talk. So AI isn't new. It's been around for decades. There have been pioneers that have sort of laid the foundation for many of the more recent advances. In the 1940s, Alan Turing, who's pictured here, developed the Turing test to determine if machine learning could display, or if machines could display intelligent behavior, or if they could think. And then in the 1950s, Arthur Samuel coined the term machine learning, and John McCarthy coined the term artificial intelligence. And during this time, or the time of these pioneers, there was lots of excitement in the field or around AI, but it wasn't always sustained. So we did see some notable advances during AI 1.0. For example, there's Shaky the robot, which was developed in the 1960s and made a lot of headlines because it could respond to human commands. And then there's Mycin, which is a rules based. It's based upon 600 rules. It's an AI system developed in the early 1970s that assisted with making treatment decisions for bacterial infections. So this could have been considered, or these could have been considered sort of the narrow AI of the time, but these innovations didn't really persist for very long. And then we have other algorithms that were developed to support broader diagnoses. So I said the mycin was, more focused on identifying bacterial infections and recommending certain treatments. But these are two models that were developed to kind of think about or address broader tasks. So there's the D-explain and internist one. Both of these were developed in the 1980s, and there was some excitement around these tools as well, but they didn't really have the impact that many were hoping that they would. So that led to, or there were periods of decreased interest as well. So some may know why I showed this picture, because I'm using this to sort of refer to those AI winters. And those were periods where there wasn't as much excitement or as much funding around AI. And the longer periods or longer AI winters occurred in the 1970s and the 1980s. And I also wanted to just mention, that there were studies back then kind of looking at clinicians' diagnostic accuracy using these decision support systems, in this case, Iliad and QMR, but looking at how or whether or not their diagnostic accuracy improved with use of these technologies. And we can see that there were some gains here, and the gains were most pronounced when we look at students' diagnostic reasoning. So they had a, let's see, they went up by about 9.1% in their diagnostic accuracy relative to residents and faculty. So again, there was, and this study was conducted by some folks out at the University of Michigan, and this was encouraging. But I encourage you to kind of think about, why is it that these technologies have not entered mainstream clinical practice, where many of us are using them as often or as much as we're using things like UpToDate and so on. So think about what could have potentially played a role here. Were there was it a process issue? Was it a structure issue? Was it a culture issue that potentially led to these technologies not being readily adopted by clinicians? So and also think about whether or not newer technologies that we are engaging with are potentially going to face a similar fate, right? So will they fall prey to that productivity paradox, as we've all heard about? So then we enter AI 2.0, and this is Jeff Hinton, who's often referred to as the godfather of AI. Did a lot of important, innovative work related to deep learning, and his work led to development of realizing the potential of things like convolutional networks, which allowed computer vision, and recurrent neural networks, which allow computers to generate and interpret human language. And Hinton wrote a paper, a viewpoint, back in 2018, predicting that AI was going to transform the practice of medicine or transform healthcare. And you may know that he recently won the Nobel Prize in Physics for his work in deep learning and artificial neural networks more specifically. So deep learning led to multiple breakthroughs in healthcare, and I would say more pretty notably image-based diagnosis. So here is a landmark study that showed that a deep learning model could accurately identify different types of skin cancer in smartphone images. And this is another study showing a deep learning model that accurately identifies benign versus malignant lesions on mammography. And this is another landmark study published in 2016. This study has been viewed over 450,000 times, but it showed that a deep learning model could accurately identify vision-threatening diabetic retinopathy on retinal fundoscopic images. It should also be noted here that this IDXR or DR, it was actually a deep learning model, or a model that was you developed to screen for diabetic retinopathy, but it also became the first autonomous AI approved by the FDA, US FDA, the United States Food and Drug Administration, back in 2018. And this model is actually has been used. So people are actually using this model in primary care, particularly. So here is another article that I just wanted to kind of point out because it's important as we, again, think about how clinicians use the outputs of these models. So in this vignette study led by colleagues here at the University of Michigan, they evaluated hospitalists, nurse practitioners, and physician assistants. They evaluated their ability to diagnose the cause of acute respiratory failure, and they basically had to determine whether or not it was pneumonia, COPD, or CHF as the cause of a patient's acute respiratory failure. So the clinicians viewed a total of 9 vignettes. Two were with a vignette where two of them were without a model, three were with standard model predictions, three were systematically biased. So they received model predictions that were systematically biased based upon things like age, BMI, or a pre-processing issue like a blurred spot in an image. And then they also viewed one hypothetical clinical consultation with a colleague. So what they showed here in this study was that clinicians' baseline diagnostic accuracy was about 73%. And with the standard AI model, without explanations, meaning the AI model providing a reason for their prediction, without that, it increased, or their diagnostic accuracy increased to 75.9%. And with explanations, it increased even more to about 77%. But you'll notice here that with a systematically biased model, without explanations, their diagnostic accuracy decreased to 62%. And with explanations, it decreased not as much, but it decreased to 63.9%. So this may lead us to sort of think about, are there issues with automation bias here? Are clinicians prone to sort of going with what the computer suggests? Or is there a vigilance issue? Should we expect that clinicians are going to be able to determine when an AI or when a model is not providing an appropriate prediction, or whether or not the context isn't appropriate? So these are things that this study kind of led us to sort of think about. So, despite concerns like automation bias and various other types of bias, AI had these tools, or these models have continued to be developed. They're going to continue to be developed. And not only are they being developed, but the FDA is approving or authorizing these models in an increasing fashion on year by year. And this is affecting or impacting every medical specialty. So, there's not a specialty that's going to be able to kind of say that this isn't going to affect me or my diagnostic reasoning. It's affecting everyone. So then came along AI 3.0, and I would say November of 2022 is when we really saw that peak of expectations, or lots of hype around the potential for AI machine learning. And this is when we started to see things like this, where we talk about this reshaping of modern medicine. And many of us recall that paper published in JAMA Internal Medicine, over 100,000 views for that one, but describing AI's potential to provide empathic responses relative to clinicians. And then we talk about things related to passing USMLE and the bar exam and so on. So this is where we see sort of that peak. But I would say even after that, I'm not sure about exactly where we are on this hype cycle, but I can say that expectations do still appear to be high, at least in my opinion. So given questions that we have about AI, and thinking about these breakthroughs, important questions have started to be answered. And I think it's really important for us to ask these questions along the lines of what is the role of the healthcare team, and how what is the patient clinician relationship going to look like? How should clinicians be trained given some of these breakthroughs? And what I'd like to show now is just kind of some of the studies that have been published more recently, kind of showing some of the potential for AI when it comes to specifically its diagnostic reasoning. So here in a study kind of evaluating AI's, more specifically GPT-4's diagnostic accuracy, the model here, it included the top diagnosis in its differential when looking at NEJM clinical pathologic conference cases. It included the top diagnosis in its differential in about 64% of these cases. But when it comes to agreeing with the final diagnosis, it only did so in about 39% of cases. And then when we look at, or in a study comparing GPT-4's probability estimates before and after diagnostic testing, this study showed that GPT-4 more accurately estimated pre-test and post-test probabilities after a negative test compared to clinicians. However, the model didn't perform as well when it comes to positive test results. So here you can see the post-test probability was more accurate than clinicians after a positive test in 2 cases. And then here's another study, and this includes both GPT-5 and GPT-4, where it's comparing the clinical reasoning of these models to medical students specifically. And in this study, GPT-4 scored on average about 4.2 points higher than students did on these clinical reasoning final exams at Stanford University. But the passing rates between medical students and GPT-4, they were not statistically different. Now, I'll also note here that GPT-4 did also do better at creating a problem list, as it scored about 16 points higher than medical students did. And then here's another study, and then in this randomized controlled trial that included residents and attending physicians. The authors here were trying to determine or assess the effect of a large language model on these clinicians' clinical reasoning. And clinicians were randomized to either use conditional or conventional resources like UpToDate or Google, or GPT-4. They were randomized to use either of those, but those in the GPT-4 arm could also use those conventional resources. Those using the conventional resources only could not use a large language model. And they wanted to determine the clinician's ability to accurately address a clinical case. These were vignettes, and this study was conducted in a test-like setting. But they were looking at they asked the participants to include their top 3 differential diagnoses, to also include factors favoring or opposing their top 3 diagnoses. They wanted them to include their final diagnosis, and then they also wanted them to include up to 3 next steps to evaluate their patients. And in overall, the mean diagnostic reasoning score, they used a rubric to come up with this score, but the mean diagnostic reasoning score was not statistically significant between the 2 groups. But what was really interesting, though, is this slide here. So GPT-4 alone actually scored better than the physician in GPT-4 or the physician in conventional resources only. So that kind of triggered some thoughts about, again, what is the role, or what will be the role of these technologies in that diagnostic process. So as we continue to evaluate the performance of these tools in the diagnostic process, as we consider their role, it's going to be important for us to, these studies are certainly important and a great step in the direction of understanding how their potential, but we're going to also have to see these studies perform and or see these how they things or how clinicians perform with these tools in real world clinical settings, and also establishing benchmarks, right, for the performance of these tools will be very important. I think it's also reasonable for us to kind of consider, if we're depending upon how we're looking at these tools, should we evaluate them with I mentioned benchmarks, but should we evaluate them in the same way or in a similar way that we use to evaluate or assess our learners, right? So here's an example of a rubric from the Society for Diagnosis in Medicine. So are these the concepts, or are these the things that we should be looking at when it comes to a model's ability to effectively perform that diagnostic process or reason clinically? All right, so that brings us to the current state of AI in medical education. And it has a minimal presence currently in medical education curricula. I'm sure that's not surprising to many of you. And AI currently is in the form of non-mandatory offerings like electives and online courses, workshops, interest groups, and so on. But this isn't going to be conducive to successfully preparing the physician workforce or the healthcare workforce to effectively engage with these technologies. We have to begin thinking about AI related competencies, and some have published studies related to this. It's important for us to think about how these fit within current ACGME competencies, and again, the need to develop new competencies that are related to AI. So back in 2021, 2022 or so, I assembled a team called the Data Augmented Technology Assisted Medical Decision Making team. And this team has been working on developing curricula designed to teach learners across the continuum of medical education about AI. So to accomplish our mission, we assembled an incredible team we have librarians, expert medical educators, medical students, house officers, computer scientists, lawyers, and so on to come together to start to think about what learners need to know about these technologies to effectively care for their patients. So our mission was or is to develop, implement, and disseminate innovative healthcare AI and ML curricula that serve as a foundation for medical educators to develop curricula specific to their own specialties. And in developing these curricula, we used certainly the diagnostic process, and we also used in evidence-based medicine or the evidence-based medicine framework for a couple reasons, because there's overlapping and related concepts, but also because when we think about a framework that in some respects is kind of tried and true, evidence-based medicine is something that's familiar to many clinicians. So taking something that may not be as familiar, embedding it into something that's familiar, we were hoping that that would be helpful. So with support from the National Academy, the University of Michigan Center for Academic Innovation, and University of Michigan Precision Health, we developed a Coursera course that includes 4 online modules that's currently available. I include the QR code there if you'd like to take a look at that. And we adapted this curriculum and embedded it into our internal medicine residency's academic half day, where we had interactive small groups, didactics, where learners were able to come together and learn those foundational concepts, but also apply them after appraising literature around artificial intelligence, diagnostic literature specifically, but appraising that diagnostic literature and applying it to clinical cases. So we studied this. We studied residents' knowledge, attitudes, and we noted positive, statistically significant differences in residents' knowledge and attitudes after our educational intervention. And the manuscript for this study is currently under review. And if you're interested in the learning objectives for those sessions, so It included 2 days, and session one again was focused mostly on those foundational concepts, and day two or day one was focused on those foundational concepts, whereas day two was focused on actually coming in and applying what they learned in sessions one and two to a clinical case. Our team also worked with the American Medical Association to develop a broader range curriculum. We include diagnosis in that one as well. This one is available on the AMA Ed Hub website. And we also developed a curriculum in partnership or sponsored by the Societies for Teacher of Family Medicine and the Gordon and Betty Moore Foundation, designed to teach primary care providers about how to use these tools in their clinical practice. And we have a video series for that. That's intentionally or specifically designed to provide primary care physicians with some of the more practical considerations when it comes to AI in clinical practice. So we are currently educating, and I'm not going to spend a lot of time on this. And the question that I wanted to ask after kind of showing those curricula that we have developed or that we are developing is whether or not that's going to be enough. And I think you would agree when I say clearly it's not. Clearly there's going to have to be a paradigm shift. There's going to have to be a change in the way that we do things. And I've suggested that we consider the biomedical model that we are currently that we're using to educate physicians. I have suggested that it's going to be important for us to kind of reconsider all of this. This Flexner report, which basically popularized the biomedical model, was published back in the 1910s or in 1910. And I'll also add that Abraham Flexner was not a physician. So just kind of rethinking that, I think, is going to be really important as we move forward when it comes to incorporating or integrating AI, if we're going to be effective in integrating that into medical education. So, based upon the literature that I've reviewed thus far, you can likely appreciate that AI will be a tool, a useful tool in the diagnostic process. But as we start to think about the convergence of human intelligence and artificial intelligence to form that augmented intelligence, you have to start to think about again how these technologies are going to become members of the healthcare team. And there's studies that are showing that collective intelligence improves clinicians' diagnostic decision making. But how do we kind of think about AI, or how will we think about AI in terms of that collective intelligence or its role in that collective intelligence? AI could be helpful in allowing us to identify blind spots. And we could also be helpful in identifying AI's blind spots. So that's where, again, we talk about that team being useful in clinical practice. So I anticipate that we're going to shift from a dyadic patient-clinician relationship to more of a triadic patient-clinician relationship, in which each member of these teams, this patient, clinician, AI team, is going to provide unique and important contributions. And perhaps this will address some of those cognitive and administrative burdens that I mentioned earlier. This here is sort of what I see as kind of what things are look like. And as I've continued my work, I'm thinking about those interactions between patient and AI and clinician, clinician and AI, and so on and so on when it comes to that diagnostic process. We're going to also have to consider those the continuum of interaction that clinicians will have with AI. Right now, we're predominantly seeing things in that level 2 area where there is still that clinician in the loop, but I anticipate that increasingly we'll see these technologies that are in that level 3, level 4 range when it comes to that clinician being in the loop. And some would even state that we have to think about how clinicians adapt to the idea of the machine being in the loop. So yeah, I've suggested that we should begin teaching AI as a fundamental tool of medicine, that it should become as fundamental to medical education as teaching the history, the physical exam, pharmacology, other staples of medical education. But I also recognize that this isn't going to happen overnight. I've suggested that we're not expecting that everyone is going to develop models or anything like that, although there's not anything wrong with that. But I suggested some, more broad goals or more realistic goals. So ensuring that learners are data savvy consumers, that they're able to advocate for their patients, that they're able to appraise and evaluate the literature around a model and also the outputs to apply those that literature and those outputs, and to also ensure that they're using these technologies responsibly and ethically. So I suggest, or I have stated that over the next 1 to 2 years, and this is something that has actually happened at Michigan, where there have been some concepts that have been taught in different courses, but it's health system sciences, clinical reasoning, clinical skills courses, evidence-based medicine courses, where I see this content being more easily integrated relative to other courses at this point. And this is what medical education looks like now, and what it has looked like. We talk about that. I'll go back here. That those pillars of medical education, but I anticipate that this is what it's going to look like eventually. So we're talking about 5 to 10 years where AI is embedded and it's almost a foundation for, or maybe even a pillar itself of medical education, whether we talk about teaching it, learners to use it in clinical practice, or even learners using these technologies for teaching and learning. So 10 years and beyond, my hope is that we are focusing more on some of those skills that I mentioned early that are essential, some of those attitudes that are essential for the diagnostic process. For example, empathy, critical thinking, communication, and teamwork. And we're moving away from some of those things that may be less important in the future. I provide some next steps here, or things that I think we should start to think about. We're going to definitely have to study and understand AI's capabilities diagnostically and in other ways as well. Study what human AI interaction looks like, and so that we can begin to effectively partner with these models, identifying areas or places where there is overlap of content. And this is also going to lead to reprioritization of content. So things that we stop teaching, that we never teach, or things that we perhaps de-emphasize in training. And then curriculum development. This is going to require multimodal instruction, multimodal assessments, and this is going to have to happen across the continuum of medical education. Doesn't mean that we should wait for everyone to become up to speed. I'm speaking specifically of clinicians, because our learners are in many respects engaging with these technologies and interested in learning about these technologies. And this is definitely going to take a multidisciplinary effort, very similar to what I described for our data MD team. I wanted to point out that a few organizations. Bob mentioned the Macy Foundation. Recommendations are forthcoming from that foundation in 2025. Same is true for this International Advisory Committee for Artificial Intelligence. Recommendations are coming, will be forthcoming for them. And then I also wanted to just point out very briefly that if you are working on things related to educational interventions to teach learners to use AI in their clinical practice, or using AI for teaching and learning or assessment purposes, if you would like to talk about publishing that into or in MedEd portal, there is a new AI collection that I'm happy to serve as a collection editor for with Alyssa Hall, and I'm happy to answer any questions if you are interested in submitting there. And I'll leave you with this quote from Osler, which I believe is highly relevant. Medicine is the science of uncertainty and the art of probability. And I'd like to thank you for inviting me again, for your time. And I look forward to answering any questions if you have them.
Thank you, Cornelius. That was terrific. Let's we have a few minutes for questions. You talked about the new things we need to teach, and you mentioned very briefly the things we can take off our plate, as we've tried, including at the conference we were both at, to achieve consensus on the things we don't need to teach anymore. I think we achieved quasi-consensus on the Krebs cycle, and maybe not, even that there was controversy. So, what are the things that you think we don't need to teach that are in the current curriculum?
So, Bob, I may be considered a big outlier here, and because I spend so much time in this space, um, I recognize that I'm an outlier, so I try to be a bit hesitant, knowing that there are some things that some people are very passionate about. But I would agree that the Krebs cycle is likely one of them. But I would say even outside of like actual medical knowledge, I think it's going to be important that we start to think about those administrative things because residents, medical students spend a lot of time doing administrative things that is potentially not conducive to them truly learning those things that they really need to learn. And I understand that some of those administrative things are important, but as things like ambient AI is really becoming popular, I think residents and students are going to start to think, well, can I use that? Or should I learn to use that sooner? Or as I'm in my transition to clerkships, is this something that I should now begin to engage with so that when I am out in clinical practice, I'll be able to effectively do so? So I think it's not just the medical knowledge things, but I would say some of those like things that are related to like rethinking how we take a medical history, rethinking, responding to portal messages and what that looks like. Those are new skills that I think learners will have to learn that may potentially allow them to stop focusing so much on other things that they're currently learning.
Okay. A lot of interest in the study that just came out on by Go et al. And it got a lot of press on the AI being better than the human, even the human with AI, and sort of the implication being the human kind of screwed things up if they intervene. So, one question about that, but I sort of maybe just riff a little bit on that. Do you think, what do you think was going on there? And do you think that all of these studies that look at AI's ability as both a question answerer and a reader of a written, nicely, neatly written, neatly packaged case really does replicate the diagnostic process, which is often messier, more iterative? Part of the act of getting a history is sort of hearing an answer, and that leads to two other questions that take you down some other alley. So how do you judge when a study like that comes out, what it really means and maybe what it doesn't mean?
Yeah. So you stated many of the things that I was actually thinking. So I mentioned the need for real world studies. So looking at how because these are cases that are written very structured. We're talking about vignettes, right? Where the messiness of the real world, right? Me being, and this is perhaps, I think it shows that AI can certainly be helpful when there's a lot of structure, when the context is not as important, so to speak, right? Whereas, when it does become a bit, quote, messy, or things are not as structured, I do get concerns about the technology's ability to um, effectively perform that diagnostic process. So I think it's important. I think it allows us to appreciate the ability of those technologies, but I don't think it means we need to say, okay, let's just stop being physicians and let AI answer all the questions. Again, I think it's a bit, when we look at that diagnostic process, there's a lot that was not included in that study. So
Mhm.
that's why, I think, again, real world it's important for us to just kind of consider that's a very controlled situation.
And peels back to your first answer, which is that, before we sort of too aggressively take all this work about knowing facts and understanding differential diagnosis and how to take a history off people's plate, we really need to be sure that these tools can actually do that real job as opposed to reading a neat case presentation, coming up with an answer. Which gets us to probably, I think, given time, the last question, and the one that always comes up and the hardest one. Someone asked, I wanted to ask, what is your response to those who are worried about medical providers being replaced by AI? I will say that both as a chair of a department and the father of a resident and father-in-law of a resident. So a little worried about that. Um, and I guess I'll push you a little bit on your first couple of slides, which were all about, at least physicians have empathy, and there are studies that show that the AI at least can mimic empathy at least as well as we can, maybe better. So what would you tell if you had kids who are thinking about being doctors over a 20 or 30-year time horizon? What do you think what's your crystal ball?
Yeah, so I'm going to be honest and say I think some So I think all specialties will need to adapt. I don't believe that physicians will be replaced. I think some tasks that they perform, and this, we have to ask whether or not this is going to be like a pseudo. Are we going to replace ourselves, right? Because I think AI is going to change our professional identity for sure, and that's going to potentially lead some to say they either want to continue in the profession or they do not, given the impact that AI is having. I don't think we're going to say everybody's going to just, but those who adapt to AI, you've heard the saying before, those who adapt to AI, those who use AI won't be replaced. I do think some specialties have to be a little bit more concerned or be a bit more innovative than others. But my expectation is that it won't. One last thing I'll really, really quickly say is we're talking about, these questions being on electronic, right? It's not truly interact. It's not that human touch. It's like on social media and things like that, as opposed to would it be even more effective, or would the clinician have been more effective than the AI if they were actually physically present and caring for the person? I think that's another thing to consider.
Great. I think we're at time. Cornelius, thank you. A terrific talk. Congratulations on the great work you're doing. Hope you survive the cold out there. If you ever get excited
Thank you.
about it being 60 degrees, that's what it is here today. We'll see everybody back next week in person and or hybrid, back to our usual format, and enjoy the day. Thanks so much.
My pleasure. Take care. Thanks, everyone.